Hello, everyone. Welcome to Black Opportunity Funds, the first of our series of health-focused town halls led by the Black Opportunity Fund, our National Health Working Group. And the focus of this Black Opportunity Fund Black Health Town Hall series is to lay the foundation for the important work of developing a national Black health strategy and policy framework. I'm Craig Wellington. I am the CEO of Black Opportunity Fund, and I'd first like to start off with an acknowledgement that we're honoring the land that we're on and the stewards of the land since time immemorial. So I'm joining you today from the city of Toronto, or Takaranto, as it's traditionally known, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Toronto is covered by Treaty 13, which was signed by the Mississaugas of the Credit, and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. We are mindful of broken covenants and the breach of trust rooted in the acquisition of land noted within these treaties, which has resulted in ongoing systematic injustices that still impact First Nations peoples until today. I invite you to join with us in standing in solidarity with all Indigenous communities and to remain individually and collectively committed to the important truth and reconciliation work that needs to be continued. We must also be cautious that we don't use the giving of land acknowledgements to become a proxy for the necessary giving of land. Many of us have also come here as settlers and immigrants in this generation or generations past. I would also like to acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and I acknowledge the shared history of our two peoples of bondage on these lands and the resulting generational trauma. Therefore, I also honor and pay tribute to the ancestors of African origin and descent, and to the elders and community stalwarts on whose shoulders we stand. We're very grateful to the Canadian Race Relations Foundation for their sponsorship support of this series. And we have a tremendous panel. I don't want to hold up much longer to get to the important work. I would like to introduce Senator Rosemary Moody, the co-chair of the Parliamentary Black Caucus and chair of the African Canadian Senators Group, and professor of pediatrics at the University of Toronto, who is also a senior neonatologist and clinical teacher at the Hospital for Sick Kids in Toronto. So, Senator Moody.
Thank you very much for your kind welcome, Craig. Good evening, everyone. You've heard that my name is Rosemary Moody. I'm a senator from Ontario. And before that, as you've heard, for about 30 years now, I've been a neonatologist and pediatrician. As a medical profession, I am all too aware of the disparities and the barriers faced by marginalized groups in healthcare. If you're here, I'd likely don't need to tell you that race undeniably plays a significant role in a person's health. But there are so many barriers to accessing healthcare facing Black Canadians, ranging from socioeconomic factors to systemic biases. For example, there's lots of evidence. Multiple studies have provided us with the confirmation that Black Canadians often face barriers to accessing timely and culturally sensitive care. Consequently, this unequal access leads to unequal outcomes. According to more recent studies, Black Canadians face higher rates of chronic health issues like diabetes, hypertension, leading again to poor health outcomes. The die are stacked against us. The impact of race on healthcare is often based on systemic disparities. These disparities themselves create barriers accessing healthcare. And to make matters worse, decades of discrimination and unequal treatment have created an environment where marginalized communities don't trust the health system that they can access when they can. Colonialism, oppression, and racism continue to have a lasting impact, in addition to present-day issues and other forms of systemic inequities. Health really, it's about access, but it's not simply about access. We all know that the broader social structure within which we exist matters. Housing, jobs, nutrition, and education are all really essential parts of a healthy life. And here again, we see the impacts of systemic discrimination. And so our health is not just impacted within the healthcare system, but in all fronts of life, in the social determinants of health. But all of you know this. I'm speaking, I think, to preaching to the converted, as they say. You see it in your communities, you see it in your families, and you see it in your work. The very valuable and important work that you do. It's why you're here this evening, because the status quo is really not acceptable. And you, like I do, want to see change. As a senator, I work with my colleagues in both houses to address these issues, but we really can't do it alone. We need the ideas, the voices of communities from coast to coast to join us in producing significant political change so that change can be brought about. We've had some success, I think. The inclusion of diabetes drugs in this new national pharmacare plan is an important step that I know is the result of our advocacy and our hard work. Recently, I toured Taibu Community Health Center, and their tireless work on diabetes in Black communities is worth lauding in my home city of Toronto. We know that real change can come when we work together. This is why this evening's work is so important, and the upcoming series that you have been planning and will spend the next couple of weeks, I guess, to have discussions in this area. They provide an opportunity for us to come together, to discuss issues and to work towards solutions, to build our voices towards real change. I'm excited to be here with you today and to hear what you have to say. And I really do have to thank the Black Opportunity Fund for inviting me to deliver some brief remarks this evening as we start. And to the expert panel members and to all of you for everything you do. Thank you.
I'd now like to thank you, Senator Moody, for those for framing the discussion so wonderfully. And I'd next like to invite forward Dr. Ato Setchiotu, the co-chair of Black Opportunity Fund's Health Working Group, who will introduce our panelists. Ato.
Thank you, Craig. Can we go to the next slide? And so for those of you who are new to Black Opportunity Fund, first thing you should know is that we back Black. We're a registered charity. We support Black communities by challenging anti-Black racism in two ways: by delivering sustainable and needs-informed capital streams managed by Black people for the benefit of Black people and Black communities. We also work nationally to strengthen collective actions by Black organizations and leaders. Next slide. We focus on a few pillars in which we see anti-Black racism: education, healthcare, entrepreneurship, arts and culture, and criminal justice. Next slide. Specific to the Health Working Group, we meet once a month, the third Thursday of every month, and you're all welcome to join us. Next slide. You met Craig Wellington. Bucole and I are the co-chairs of the Health Working Group. Next slide. And just to give you some background to why we need a town hall series focused on Black people's health in Canada. Next slide. We know that we're 1.5 million people in Canada. That's 4.3% of the population. But we continue to experience health inequities, disparities, poor health outcomes relative to other groups. You name the situation. It could be mental health, cancer care and treatment, COVID pandemic outcomes, neonatal care, obstetrical care, cancer screening, COVID pandemic. The health of Black people in Canada has been specifically impacted by anti-Black racism, and we're less likely to benefit from health services than other groups. Next slide. So we've identified a need for a national comprehensive strategy to improve the health of Black people in Canada. And there is a need for a sustainable strategy to address the health of Black people in Canada by engaging Black communities towards developing a national strategy. Next slide. And so we propose 4 town halls to lay the foundation to engage communities for future development. Next slide. And we're going to do this by engaging with members of Black community, including health professionals, community leaders, people that with lived experiences, Black organizations, people who've been doing this work for many, many years. And we've invited policymakers, practitioners, decision makers. This project builds on the track record of Black Opportunity Fund in mobilizing Black communities towards action. Next slide. So today's session is titled Priorities for Black Health Services and Policies, Barriers, Issues, and Gaps. The objectives today are threefold: to identify and discuss the major issues related to Black people's health in Canada, to discuss how policies and services can better respond to the health of Black people in Canada, and to gather feedback from Black communities related to how Black Opportunity Fund policymakers and practitioners can best address health inequities in Canada. Next slide. We have a second session titled Models of Success, May 16, 2024, another webinar. We have people who've been doing great work. Mr. Anthony Henry, who is part of the Walnut Foundation, a prostate cancer care group. Members of the Health Association of African Canadians in Nova Scotia, Reverend Simmons, Sharon Davis Murdoch, Dee Adegobaje from Ruth House in Calgary, Angela Carter, who's spearheading the Peel Black Health and Social Services Hub, and of course, Dion Sinclair is our moderator. Next slide. Our third session is on July 18th. It's titled Capitalizing on Black People's Strength, Black Health Leaders and Health Professionals to Improve Health Services Delivery. Again, we have a distinguished group of participants, and Dr. Anya Noram will be moderating that session. Next slide. And finally, our last session, hopefully will be part of the 4th National Black Canadian Summit in Montreal on the weekend of September 6th in person. And we have Senator Meiji. We have distinguished guests such as Dr. Kwame McKenzie, Dr. Nakashi Lamte, Dr. Akwatu Kente, and members of the Public Health Agency of Canada. Next slide. So just a few dates for you to remember: May 16th, July 18th, and then the weekend of September 6th in Montreal. Next slide. Just a little bit of housekeeping before we introduce our panelists. We are recording this session. We have simultaneous translation, both French and English. If you look at the icon on the bottom of your screen, the globe icon, you can choose your language of choice. We will have breakout rooms in 3 in English and 1 in French. I'll give you more color on what that looks like before we get into the breakout rooms. I will be moderating and keeping track of all the questions in the Q&A. We also have a chat room, so you can drop your questions in the chat room. And we realize that we're not going to be able to look at all the questions, so we do have an email address. I'll be dropping that to the chat room as well, and we can continue this conversation. Next slide. So this stage, I'd like to introduce our panelists. We have Dr. Jude Marie-Sena, who's an associate professor of School of Psychology, chair of the Interdisciplinary Center for Black Health, and director of the Vulnerability, Trauma, Resilience, and Culture Research Laboratory in Ottawa. Dr. Bukola Salami needs no introduction. She's a professor of the Cummings School of Medicine, University of Calgary, and scientific director, EDI Inclusion, and Alberta Children's Hospital Research Institute. Next slide. Dr. Edouard Croissy is an associate professor and researcher at the University of Montreal, Faculty of Medicine, and a member of the Research Center of University Institute of Mental Health of Montreal. And Dr. Dion Sinclair is Vice President, Clinical Operations and Chief Nursing Officer at KMH. And one of the moderators is Valerie Gazimar, who's a nurse in Montreal, but wears many hats. But today she's part of the Realm of Haitian nurses in Montreal. Next slide. So, I'm reminded of Prime Minister Justin Trudeau's announcement of the extension of the International Decade of Peoples of African Descent until 2028. Many of you in this chat room have been doing the great work for decades. We know that there's been anti-Black racism affecting the health of Black Canadians for decades and centuries before, and even during this decade of announcement, and even beyond this 2028. So I think this is a huge opportunity. We'd like to thank you all for participating in this, and let's move this agenda forward and get some work done. At this stage, I'd like to introduce Dr. Jude Marie-Sena to start the conversation.
I will be the one who will start the conversation. I thought it was Dr. Bukola. I'm sorry. So let me share my screen, and you will be able to tell me what you see, if you see my notes or not. And give me once again. And tell me, you can see my notes or not? You see my notes? Ato, do you see my notes?
We can. Yes, we can. Thank you.
Yeah, let me. And now you cannot. You can still see my notes or not?
Yes,
No.
we can.
No, you have
No.
your slides perfect. We don't have your notes.
Okay, thank you. So I type on my presentation when racism makes you sick, because I will try to talk about racial discrimination in the healthcare system, because if you look at the healthcare system and more importantly, if you look at the research available, you will find there are qualitative research, but we don't have quantitative research on racial discrimination in the healthcare system. But let me start first with an experience. In February 2019, Mrs. Dawson, a 37-year-old Black woman, gives birth to her first child in an Ottawa hospital. She can't wait to hold her son. She told me in an interview, "I always dreamed of being a mother of at least 3 children." But the labor process is not going as planned. She suffered and bled a lot and had difficulty breathing. Mrs. Dawson, who had always said she will not want an epidural, called the nurse who was looking after her and asked for an epidural. The nurse replied, "Madam, I will not wake the anesthetist. There has never been a delivery without pain." In addition, Mrs. Dawson and her husband heard in the corridor as the nurse laughed and told another nurse, "She's just as lazy as these all modern Black women." A few minutes later, Mrs. Dawson fainted and an emergency C-section was performed. As she woke up holding her baby boy, she was told that she had undergone a tubal ligation without her consent because the health staff thought she was having her third child and will not want anymore. Even her husband, anxiously waiting for his wife to come out of the operating room, was not consulted. Each year in Canada, Indigenous, Black, and other women of color are sterilized without their consent. 2 weeks ago, I received a call from a Black man seeking mental health care for his wife because as she met her family physician at the end of January to plan contraception after giving birth to her first daughter in November 2023, it was there she learned that she had been sterilized during her C-section. The doctor himself was shocked to learn that she did not know she was sterilized. But Mrs. Dawson's case is not an isolated one. On contrary, the Black mental health survey in Canada we conducted in 2020, 53.1% of people from the Black communities said they experienced major racial discrimination in hospitals and health services. Every day, Black people are facing health disparities and poor care. Reducing and eliminating these disparities is a key to remove barriers and fill the gaps on Black health. Because when we look at the association between the experience of racial discrimination in the healthcare system and mental health, what we see is those who experience major racial discrimination in the healthcare system, they are more likely to present severe symptoms of depression. It is the same case for post-traumatic stress disorder and anxiety. And also, they are more likely to experience suicidal ideations. And more importantly, they were more number to perpetrate suicidal attempts. And when we look at both racial discrimination in the healthcare system and everyday racial discrimination, they were able to predict low self-esteem, but also psychosomatic symptoms, which are very important in the Black communities, because usually people from the Black communities, they experience mental health with the body. You will hear from them saying, we have back pain, we have headache, and without medical reasons. And they are also more likely to have suicidal ideations. And more importantly, microaggressions played an important role in suicidal ideations in the Black communities. However, it is a systemic crisis, as our study showed that many people from the Black communities experience major racial discrimination in different environments and contexts in Canada. For example, 57% of people from the Black communities reported having experienced major racial discrimination in the workplace, 55% in hiring process, 55% of them were victims of racial profiling and violent attitudes from the police. 47% in housing, 46% in bank loan. However, the environment where people from the Black communities experience more major racial discrimination is in education. More than 60% of Black people said they experienced major racial discrimination in schools and universities. And there also, major racial discrimination is related to more symptoms of depression, more symptoms of PTSD, more symptoms of anxiety, more low self-esteem. And one of the comments we had and critics we had from people was, oh, yes, it is great data, but it was among a non-representative sample, and it was among Black people from 15 to 40 years old. And what we did was to conduct the Black Vax study among a representative symptoms of a representative sample of Black people. And we were able to recruit 48 peer research associates who are peer recruiters, Black students across the country. And we were able to recruit people to collect data in 7 provinces, Ontario, Quebec, Alberta, and others, where 89.3% of Black people are living. And we were able to collect data among more than 2,000 participants from the Black communities. And we were able to collect data on COVID-19 consequences, but also COVID-19 infection, COVID-19 vaccination rates. And we just published the article on COVID-19 vaccine uptake, where you can see the factors related to COVID-19 vaccine uptake, and racial discrimination is one of the most important factors that prevent Black people to be vaccinated against COVID-19. And what the representative data show us is the fact that everywhere in Canada, you have in each province, the 7 provinces, you have a lot of Black people who are experiencing major racial discrimination in the healthcare system. And Ontario is one of them, and you have more than about 40% of Black people who said they experienced major racial discrimination in Ontario. But British Columbia is the place where people from the Black communities experienced more major racial discrimination in the healthcare system. And one of the things which is very interesting was Quebec, because our perception, I'm a Francophone person, and our perception is, oh, Quebec is worst, but it is not true. And when you consider people in Quebec, what they said is, if you ask them about perception of racial discrimination, they said, yes, in Quebec, people experience more major racial discrimination than elsewhere in Canada. But when you ask them about their own experience, they compared to Ontario, for example, they experience less major racial discrimination in the healthcare system. It is important to note that, because sometimes we think in Ontario we are good enough, and I think also sometimes there is that Toronto-centric approach where when it comes to talk about Black health, we talk just in Toronto and that's it. And I think it is important to address the healthcare system as a whole, and to engage people to put in place policies to reduce and eliminate racial discrimination in the healthcare system. And we look at also some consequences. And if you look at there, you will see people who experience more major racial discrimination. People who experience major racial discrimination in the healthcare system, they had more conspiracy beliefs. They had more stressors related to COVID-19, less resilience, community resilience, but also more symptoms of stress, more symptoms of anxiety, more symptoms of depression. They had more COVID-19 mistrust, COVID-19 vaccine mistrust, and also they had a mistrust in the government. And when the government tried to have health institutions, health messages, and they don't believe to that messages. And also, when you look at depression, they are more than 2 times more likely to have severe symptoms of depression, 2 times more likely to have severe symptoms of anxiety, more than 2 times more likely to have severe symptoms of stress, and they were 35 less likely to get vaccinated against COVID-19. And we try to understand what are the implications of our studies. First, for research, this study shows the urgent need to conduct studies to determine the impact of racial discrimination experienced in health services on a range of health behaviors among Black people, including health service attendants, for example, screening for chronic diseases, breast cancer, cervical cancer, prostate cancer, diabetes. It is well known that it is a well-known fact that Black people often go to health services when their case is getting worse and the situation is critical. Because of this, Black people are more likely to be diagnosed with cancer during an initial screening. And we need more research to understand the impact of racial discrimination in the healthcare system on a range of diseases. We also need some qualitative studies to better understand the dynamics in the healthcare system, to understand the care dynamics and the reasons behind this high proportion of racial discrimination in the healthcare system. And these results also argue in favor of race-based data collection in the healthcare system. And we just have Nova Scotia, who has a pilot project, but it is something that is important, and it is an urgent need for people from the Black communities. We want to know the quality of care people from the Black community receives. We want to know about the practices, but also the training. And about training, universities and colleges, they have a major role to play in ensuring that no nurse, physician, or other healthcare professional graduates without a solid training in anti-racist, culturally appropriate, and safe care. And institutions also, they need to provide they need to have policies, but also they need to provide training to their mental health, to their mental and physical health professionals. And for policies on discrimination and barriers related to institutional policies, a thorough solution-based analysis should be imposed by provincial governments to each health institution with clear defined objectives to be achieved over a period to reduce and then eliminate racism and institutional barriers to care for Black people. And public health agencies should also address the mistrust created by racial discrimination into the development and implementations of their programs, strategies, tools, and campaigns. And I want to finish by saying the fact that racial discrimination in the healthcare system is a major public health threat. And it is not just a major public health threat for Black people, it is for the whole population, because the association observed with COVID-19 uptake and mistrust, conspiracy theories show this is not a problem that only concerns Black people, but a threat to the health of the general population. Yes, it is first and foremost a threat to the physical and mental health of Black communities, but by reinforcing distrustful behaviors and unadapted health practices in Black communities, it endangers of the health of the entire population. This leads to the conclusion that health equity is not just about minority communities, but is first and foremost a population and public health issue, and that must mobilize the entire healthcare system. And what we need is to liberate the system, liberate the healthcare system, and also to bring Black people together as we are doing today, but to know that sometimes the system will not make for us. And yes, we always say it is important to do with us, but we have to do for ourselves, and we have to make the pressure, enough pressure to let them know that we will not accept nothing than what is better, nothing than what is the best for the health of our populations, for the health of our communities. And this is why I really think together we are the solution to remove that barriers and prevent racial discrimination for Black people in the healthcare system. Thank you.
Thank you, Dr. Sinha, and really, really important work, and also just highlighting the intersection between anti-Black racism in workplace and in housing, and how it could affect your mental health and your overall general health and your trust in the system. So thank you for the great work that you do. I just want to remind everyone that we do have simultaneous interpretation in both French and English. And please, we're gonna save the questions in the Q&A for the end of the talks. But if Dr. Edward Kwasi is ready, Dr. Edward Kwasi is next. Thank you.
Yes. Can you see my slide?
Yes, we can. Thank you.
Very good. So, I will present in French. Merci beaucoup de l'invitation d'être ici aujourd'hui. Et c'est un plaisir, en fait, parce que l'association médicale des personnes de race noire que je représente là, au Québec, on pourrait dire, cette association a dans son ADN le souci de promouvoir la santé des Noirs au Québec. Alors, je voudrais profiter de cette occasion pour parler de ce qu'on fait au Québec pour amener donc les communautés noires à jouir d'une meilleure santé et notre travail principalement dans le milieu académique. Alors, notre association, brièvement, elle existe depuis plus de 30 ans maintenant. Et en anglais, on s'appelle Québec Black Medical Association. Et elle regroupe à la fois des anglophones et des francophones. Alors, can I have a previous slide, please? Thank you. So, je voulais juste utiliser cette diapo pour vous dire qu'on travaille ensemble, francophones et anglophones au Québec, parce que les francophones au Québec, on est très sensibles, évidemment, au sentiment d'isolement des francophones à l'intérieur de l'océan anglophone de l'Amérique du Nord. Et de l'autre côté, dans notre association, on est sensible également au sentiment de double minorité des anglophones par le fait qu'ils sont d'expression anglophone en termes de langue et ils sont noirs. Donc, on pense qu'à l'intérieur de notre association, on vit ces réalités-là et on est capable donc de nous intéresser de très près à ce qui se passe dans notre société ici au Québec. Alors, notre association a en plus les professionnels qui y travaillent, mais notre association a une aile jeunesse qu'on appelle CBMA Youth Initiative en anglais. Et, les jeunes apportent évidemment tout leur dynamisme à l'association et tout en profitant évidemment de l'expérience des plus anciens. Next slide, please. Alors, je voudrais dire donc un mot de ce qu'on fait en termes de santé des Noirs donc au Québec. Pour servir un peu d'exemple hein, à ce que le docteur Jules-Marie là tantôt a dit. Et donc le plan que je propose, c'est de me concentrer essentiellement sur deux aspects. Le premier, c'est le travail qu'on fait pour améliorer la représentation des étudiants et des étudiantes noirs dans les écoles qui donnent des enseignements dans le domaine de la profession de la santé, ici au Québec. Et le deuxième aspect, c'est la nécessité de développer et de renforcer les capacités des communautés noires pour prendre soin de leurs problèmes de santé. Alors, dans chaque cas, je vais mentionner qu'est-ce qu'on fait comme association, comme contribution à ces deux aspects-là. Et je dirais également un mot des partenaires avec lesquels on travaille. Next slide, please. Alors, le contexte de ceci, pour le premier aspect, donc sur la question de la représentation des Noirs dans le système de santé au Québec. Alors, il y a un constat, certainement, surtout à l'échelle du Canada, dans son ensemble, que les professionnels de la santé représentent les personnes noires, je veux dire, ne sont pas très bien représentés là, dans les professions de la santé. Il y a très peu de médecins noirs, très peu de psychologues noirs, très peu de pharmaciens noirs, très peu de travailleurs sociaux noirs. Alors, non, ça, c'est un constat à l'échelle du Canada. Puis, de l'autre côté, on se rend compte que euh, les, on pense, en fait, ça peut être une des raisons pour expliquer le fait que les Noirs, de façon générale, consultent très peu pour les soins de santé euh, au Canada. Et donc, nous, on pense que la sous-représentation au niveau des professions de la santé, ça peut jouer un rôle. De même que, on peut le voir, la sous-représentation des étudiantes et des étudiants noirs dans les programmes de santé dans nos universités. Alors, surtout en médecine, en fait. Et à partir de ce constat-là, et on a fait à l'Université de Montréal un groupe de travail qui s'est penché spécifiquement sur la représentation des étudiantes et des étudiants noirs dans les sciences de la santé. Et next slide, please. Et alors, ce groupe, donc, s'est mis au travail et il a été formé là, en 2020 et en 2021, le groupe a organisé un forum qu'on a appelé citoyen parce que il rassemblait des citoyens de tous horizons. Il rassemblait également des représentants des différentes universités, notamment les trois universités francophones qui donnent des programmes de sciences de la santé, principalement de médecine, c'est-à-dire Laval, Sherbrooke et Montréal, ainsi que l'université de McGill aussi, et plusieurs organisations communautaires qui représentent les Noirs au Québec. Alors, ça a été l'occasion de discuter des obstacles, des barrières à l'admission des étudiants noirs dans les programmes universitaires qui forment les professionnels de la santé. Next slide, please. Et le forum a permis donc de donner des suggestions pour un plan d'action qui a vu le jour là, dès 2022 à l'Université de Montréal. Next slide, please. Et alors, ce plan d'action avait principalement 5 axes prioritaires d'intervention. Next slide. Et alors, les 5 axes, je vous les résume très rapidement. Le premier, c'est le recrutement. Le deuxième, l'admission. Donc, les contenus même de l'admission, le processus
Excuse
de
me,
l'admission.
Dr. Kwasi?
Yes.
Yeah, can you speak a little bit louder? The interpreter is having a difficult time hearing you, just for interpretation.
Okay. Very
Thank
good. Thank you. I will try. So, I hope you hear me well now. Alors, donc, je disais qu'il y a 5 axes principaux d'intervention. Le premier, c'est le recrutement des étudiantes et des étudiants. Le deuxième axe, c'est l'admission, le processus d'admission dans les programmes de médecine. Le troisième axe a trait au curriculum donc, du programme de médecine, le contenu même de ce qui est enseigné aux étudiants. Le quatrième axe concerne l'environnement d'apprentissage, en fait, de façon à s'assurer que les étudiants noirs étudient dans un environnement sécuritaire qui est exempt de toute forme d'agression, d'intimidation. Et le cinquième axe, c'est le soutien financier pour notamment favoriser l'admission des étudiants qui ont un statut socio-économique plus faible, par exemple. Next slide, please. Alors, donc les étapes suivantes, donc ce plan a été officiellement lancé en 2022, à l'automne 2022. Puis, à l'automne dernier, donc 2023, on a fait un premier suivi. Alors, rapidement, pour vous dire qu'est-ce qui ressort de ce travail-ci, il y a plusieurs aspects positifs, encourageants, et bien entendu, il y en a quelques-uns qui sont moins bons et sur lesquels on continue de travailler. Alors, parmi les aspects très positifs, je dois dire qu'en termes de processus d'admission, il existait peu, sinon pas du tout, d'évaluateurs noirs dans le processus d'admission des étudiants en médecine à l'Université de Montréal. Il y a par exemple une étape du processus d'admission qui s'appelle les mini-entrevues, les MEM, mini-entrevues multiples, où les étudiants rencontrent donc des évaluateurs, des professionnels de la santé ou des représentants de la communauté. Eh bien, pendant longtemps, il n'y avait pas du tout d'évaluateurs noirs sur ces comités-là. Et après l'adoption donc du plan d'action, eh bien, les évaluateurs noirs ont été intégrés dans les comités d'entrevue, des mini-entrevues multiples. Et donc, 2021, 2022, 2023 également. Et pour le prochain concours, 2023-2024, il y aura également des évaluateurs noirs intégrés dans les comités de... Alors, ça c'est un très bon progrès à notre point de vue. Euh, du point de vue du recrutement, euh, nous, notre aile jeunesse travaille énormément en collaboration avec la responsable de l'Université de Montréal pour mettre en place un programme de mentorat, et quelque chose qui nous tient à cœur depuis très longtemps et qu'on faisait avec nos moyens. Et là, l'université s'implique et facilite, si on veut, ce programme-là de mentorat où les jeunes étudiants de l'université sont disponibles, vont dans les écoles secondaires et amènent donc les étudiants du secondaire, notamment niveau 3, 4, 5, là, à s'intéresser davantage au programme d'enseignement là, qui mène à la profession de la santé. Alors, il n'y a pas que les étudiants qui sont convoqués ou qui sont suivis. Alors, il y a des réunions d'information où non seulement les étudiants sont là, les élèves du secondaire, je devrais dire, mais aussi leurs parents. Et on se rend compte jusqu'à quel point l'information n'est pas toujours disponible, n'est pas toujours bien expliquée aux parents, savoir qu'est-ce qu'il faut faire, là, par exemple, pour entrer dans un programme d'une profession de la santé, spécifiquement là, à l'Université de Montréal. Parmi les aspects qui sont moins bons actuellement et qu'on veut travailler, euh, avant la mise en place du plan d'action, je disais que très peu d'étudiants en médecine étaient noirs. Il y avait 2 ou 3 étudiants en moyenne sur les cohortes de plus de 300 étudiants en première année. Mais à partir de l'adoption du plan d'action, ce nombre a bondi à 19 étudiants. Alors, on s'est dit, mission accomplie, c'est un très bon pas. Ça, c'était pour la première année, euh, année 2022-2023. Mais malheureusement, 2023-2024, quand on a fait notre bilan donc en septembre dernier, on s'est rendu compte que le nombre a baissé. De 19, on est passé à 5 étudiants seulement recrutés en première année. 5 étudiants noirs recrutés en première année. Alors, on est évidemment très déçus de cette nouvelle-là et on est en train de travailler à l'Université de Montréal pour comprendre les raisons de cette diminution. Elles sont multiples, là, sans doute, et on veut continuer à favoriser donc l'admission des étudiants et des étudiantes noirs dans le programme de médecine dans les universités québécoises. Alors, donc, nous, on pense que ce genre d'approche, donc de travailler conjointement avec les universités, euh, c'est-à-dire associations communautaires, universités, cela ne peut que aider la cause des Noirs au Québec. Et on a publié notre approche, notre façon de travailler là, dans le blog du journal canadien CNED, journal de l'Association médicale canadienne. Et donc, pour dire comment est-ce que, à notre sens, cette forme-là de co-construction peut permettre d'aboutir à des résultats très positifs, où ce n'est pas l'université toute seule qui décide en haut là, de sa tour, mais en collaboration avec les associations qui représentent les communautés noires. Prochaine diapo, s'il vous plaît. Next slide, please. Alors, je vais dire un mot sur les questions de données, de collecte de données. Alors, en fait, on sait qu'il existe très peu de données spécifiquement sur la santé des populations noires au Québec. Il y en a peut-être un peu plus dans le reste du Canada, mais au Québec, très, très peu. Et on se doute bien que l'ambiance générale qui tend à ignorer et à dire que en fait, il n'y a pas de racisme systémique au Québec, il y est certainement pour quelque chose. Donc, le déni ici euh, est probablement un des facteurs importants. Et, mais alors, on se rend compte que durant la crise de la pandémie COVID-19, par exemple, il y a des études qui tendent à montrer que la population noire est davantage affectée que les autres populations et que des efforts spécifiques doivent être dirigés là pour améliorer la santé des Noirs au Québec. Alors, je donne ici l'exemple de deux articles essentiellement publiés récemment euh, dans le contexte là, de la COVID. Et le premier article, c'est celui d'un groupe de chercheurs, dont un qui s'appelle Jean-Michel Leduc, qui est infectiologue, et le travail portait sur 19, 19 hôpitaux au Québec durant la pandémie, durant la première vague de la pandémie à COVID-19. Et ce que ce travail-là révèle très clairement, c'est que les populations noires ainsi que les latinos présentent un taux d'infection à COVID-19 plus élevé que le reste de la population. Alors, ici, c'était très, très clair. Deuxième article dont je voudrais parler. Next slide, please. Alors, next slide. Alors, le deuxième article ici, c'est pour aller un peu dans le même sens que Jude-Marie qui nous a présenté tantôt les données sur plusieurs les provinces du Canada et qui semblait dire qu'au Québec, l'impression donc du racisme est peut-être moins forte que ce qu'on peut ressentir, par exemple, que ce qu'on pensait en tous les cas par rapport aux autres provinces. Alors ici, le travail d'un groupe de médias auquel a collaboré aussi des gens d'une organisation communautaire qui est la BCRC, Black Community Resource Center. Et ces gens-là ont montré clairement que les anglophones du Québec euh, avaient le sentiment, étaient beaucoup moins informés sur la COVID-19 pendant la pandémie. Et de façon générale, donc les anglophones du Québec euh, ont un sentiment d'insatisfaction beaucoup plus grande vis-à-vis du système de santé au Québec comparé aux francophones noirs. Donc, ici, les Noirs anglophones vivent donc ce qu'ils appellent donc la double minorité, celle d'être noir et celle de parler anglais. Donc, ce sont là des facteurs importants dont on doit tenir compte. Next slide, please. OK. Alors, ici, je voulais brièvement mentionner le nom des gens avec qui on travaille là et qui s'intéressent beaucoup à toute la question du racisme dans le système de santé et avec qui j'ai échangé beaucoup pour venir participer à cette session-ci. Wolf Tima, que plusieurs connaissent sans doute au Québec, qui a la double formation de juriste et de médecin, qui est actuellement résident en psychiatrie, fin de deuxième année, et qui a un intérêt très grand là pour racisme et santé mentale. J'ai parlé aussi avec Dina Mombo, docteur Mombo, qui est PhD et qui travaille énormément sur ce qui représente en fait les meilleures études, là, les meilleures approches en termes de collecte des données euh, en lien avec le racisme et la santé au Québec. Puis, je mis également ici évidemment, Jean-Michel Leduc, la liste est longue là, mais j'en cite quelques-uns pour ne pas oublier. Jean-Michel Leduc, que nous on considère comme un des meilleurs alliés de la lutte contre le racisme anti-noir au Québec. Et comme je l'ai mentionné, il est un des co-responsables du comité, du groupe de travail qui s'occupe là de promouvoir le recrutement des étudiantes et des étudiants noirs à l'Université de Montréal et qui travaille lui-même sur plusieurs problèmes de santé que vivent les Noirs au Québec. Alors, rapidement, nous faisons partie d'un groupe de travail qui étudie également le bien-être des Noirs à Montréal. Et dans ce groupe, il y a des représentants de la santé publique de Montréal, avec notamment Larissa Ouedraogo, les représentants de la BCRC que j'ai mentionné tantôt, notamment Ryan Francis, représentant de l'association des Jamaïcains de Montréal, Jamaican Association of Montreal. Et donc, les gens qui eux-mêmes collaborent énormément avec les universités du Québec, d'autres organisations pour promouvoir la santé des Noirs au Québec. Alors, je vais m'arrêter ici en soulignant donc les deux aspects qui me semblent être des priorités pour améliorer la santé des Noirs, à savoir la nécessité de développer et de renforcer notre capacité comme communauté. Et deuxième aspect, celui de collecter davantage de données probantes de façon systématique plutôt qu'un peu au hasard et avec des analyses indirectes là, pour connaître l'impact du racisme anti-noir sur la santé des Noirs et trouver les meilleures solutions possibles. Alors, je vais m'arrêter ici et merci beaucoup de votre attention. Thank you very much.
And again, thank you, Dr. Kwasi. That's a lot of work that QBMA is doing in Quebec. So congratulations on that. I'm especially, as a medical grad, I'm especially excited about the upstream work you're doing, recruiting students at the level high schools, the mentorship, the culturally sensitive application process. It's only going to help the Black community in Quebec seeing Black faces in healthcare. So thank you for the work that you do. So last panelist is Dr. Bukola Salami. I'll leave the mic to you, Bukola.
Thank you very much for this opportunity to present. I'm Bukola Salami. I am a professor. I'm just going to put this on slideshow, if I can. I'm Bukola Salami. I'm a professor at the University of Calgary and a Tier 1 Canada Research Chair in Black and Racialized People's Health. So I'd like to acknowledge that I am currently located in Calgary, Treaty 7 territory, which includes the Blackfoot Confederacy, comprised of the Sika, Pikanai, and Kenai First Nation, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Biespau Goodstoney First Nation. And the city of Calgary is also home to Métis Nation of Alberta. And I reaffirm my commitment to work in parallel path with Indigenous population and Indigenous sovereignty. We know that there's around 1.5 million Black people in Canada, and that is 4.3% of the population, which has grown over time. Now we have, it used to be 3.5, and now we have 4.3. We know that our population will likely, we have one of the fastest growing populations in Canada, and will likely exceed 3.0 by 2041. That over 40.9% of Black populations in Canada are Canadian born. So we have historical as opposed to other communities. We have communities that have been here for like 10 up to 10 generations in Canada. The Black population in Canada identifies with over 300 ethnic and cultural groups. So there are not communities. There's not one community, but there are communities. Now, before I proceed in terms of talking about our current state, I want us to reflect on our history. So we know that we have history of slavery, history of environmental discrimination, environmental policy that specifically banned Black people from coming to Canada, racism in all sectors of society, denial of entry into educational program, and unethical research. And what many of this has contributed to is lack of trust in the healthcare system. We want at a town hall like this in 2020, and we saw that lack of trust in our community spheres in terms of taking the COVID-19 pandemic. We know that the workforce, including the health workforce, is like a cappuccino. It's Black underneath and white on top. And sometimes we sprinkle a little bit of Blackness to create an illusion. And this has severe consequences, including consequences related to higher mortality rate in COVID, because when you see those at the bottom that are all Black, when they are the ones actually providing the direct care, while the white are in offices, then that leads to disparities in terms of people's exposure to illness. We also know that we have histories of denial of Black people in the profession. So the story I have here is Ruma Utenda, who was denied entry in Alberta, I think around the 1950s or maybe the 1920s, between the 1920 and 1950. She was denied entry into the nursing profession in Alberta. The picture of her there is she ended up going to BC to become a teacher, and she was able to successfully become a teacher, and she was retiring there as a principal upon her retirement. We also know we have history, Canada's history of racist immigration policy. There was a law in Canada that actually banned people between 1910 and 1967 or 1969 entry into Canada based on the color of their skin. If you're deemed unsuited to the climate or requirement of Canada. And just in case Black people did not know that, we are trying to say you're not welcome here. There was a law that was proposed that the Negro race is deemed unsuitable to the climate and requirement of Canada. This law was not passed, but the initial law was still in place, but it had consequences at the borders. We know that anti-Black racism has been, one of the factors that contribute to that. So when healthcare professionals are not able to properly access Black skin color for signs of bleeding, that can lead to severe consequences. We've also seen consequences of Black people experiencing health deterioration, with mental health going to emergency department and dying from the perception and anti-Black racism in emergency departments. So as both of my colleagues, Dr. Kosi and Dr. Senat said, Black population had the highest COVID-19 mortality rate in 2020. And some of the factors, as I said, that contributed to that is segregation in the workforce and the intersection of anti-Black racism and income inequality. We also know that Black population have a higher rate of HIV and AIDS, both men and women, prostate cancer in men and breast cancer in women, and cardiovascular disease, as well as diabetes in our population. And one of the challenges we have some of this, but there are some conditions that we have really limited data on. Try searching for data on diabetes among Black people. And I will be surprised if you find more than 5 exclusive studies that have been done on diabetes among Black people. And there are several of these conditions too that we don't really have much data on. And, during the COVID-19 pandemic, of course, one of the challenges when people do not trust the system is misinformation and disinformation. And that also leads to barriers in terms of, preventive care and, following recommendations because people do not trust the system. In my research, we've also found that there are several aspects of racism in the workforce. So, for example, racism contributes to inequalities, including mental health. So, someone said, I grew up with so much internalized anti-Blackness. God, I hated myself. I wanted to be white so bad. I wanted to have straight hair. I wanted to have lighter lips. I wanted smaller lips. So this youth, was crossing the street one day. Someone threw a sloppy at her, called her the N-word, and then she was sleeping over at the friend's house, and the friend made fun of her lips. And she has continued to internalize this and continues to influence her mental health. Black male youths also talked about this whole perception that toxic masculinity is a male thing. So oftentimes, as a white woman, you're innocent until you're proven guilty. That is not the same for Black men. You're guilty until you're proven innocent, and that has mental health consequences. Parents have talked about, calling HealthLink and asking, that, their child is experiencing health issues, and people asking them if their child is blue, and they're like, no, my child is not blue. So the lack of anti-racism embedded in the educational system has severe consequences, including in assessment and health outcomes. And racism in healthcare provisions. So, we see different aspects of racism in healthcare provisions, or even mental health therapists not being able to respond to racist experiences. So someone says, I'm experiencing racism. And then the therapist is like, oh, what? Are you sure? The person repeats again. And the therapist just says something else because they don't know how to deal with it. And Black professionals experience also racism in the workforce. I want to also talk about the importance of considering the intersections with spirituality and religion in terms of addressing mental health and improving outcomes within our Black population. This was an interview I conducted with a Somali mom who told me that a child had been sent back. Sorry, I didn't write that Quran. Well, my huge apologies. She told me that a child has been, sent back to Somalia, and I asked what the child was getting, and sorry, that spelling is wrong. The child was getting the Holy Quran. And I'm like, is the child, how is things going? Yes, it's not 100%, but it was sure from a nonverbal cues that it was not great. So again, the influences of a Western perspective related to addressing health challenges, and the lack of ability to embrace diverse perspective, and also the trust that people have not developed in the system to be able to help them. De-skilling, sometimes we think children's health is just constrained within, is very individualistic centered, but children's lives are contained within the context of their family. So when parents experience de-skilling, that has multi-generational effect, and what we are beginning to see that we need to shed more light on is the intergenerational influences of racism on Black communities, because we are beginning to see that Black communities, the more you've been here, the more influences of mental health challenges. So we need to shed more light on that. The COVID-19 pandemic. I did a study to look at the influence of COVID-19 pandemic, mental health of Black youths during the COVID-19 pandemic and after. And the Black youths in my study said, you should ask about Black Lives Matter movement. And people talked about Black Lives Matter movement and how the re-traumatization related to that movement continues to impact on their mental health. Access to healthcare. So oftentimes, racism does not exist in isolation. It reproduces and also intersects with income inequality to contribute to poor health outcomes. So because of racism, it could reproduce employment discrimination, which then lower income. And then the fact that you have lower income and the racism that you also experience in the healthcare system can also intersect. So in this case, you are asking someone for a psychologist, they need a psychologist, but they do not have the resources, the financial resources to be able to get access. I did a study to look at, pap smear and mammogram screening among Black women, and realized that there are disparities in pap smear and mammogram screening among Black and white women. I should say that Black women did not have the worst outcomes of this group, but significant disparities. So 18% of Black women had never had a pap smear done in their lifetime. So let's say, we are looking here, we have 100 people, and if this was all Black women in our population now, then we would say, maybe 20 of those people, 20 people in this audience wouldn't have ever had pap smear done. And then, of course, mammogram screening too, we found disparities. But the disparities in pap smear screening was more significant. We also looked at access to healthcare for Black women, and Black women talked about the lack of cultural sensitivity, cultural appropriateness, and the fact that they prefer a Black nurse, they prefer a Black healthcare professional providing care for them. Sorry, I'm trying to go fast because I know the time is late. So we also looked at mental health of immigrant population. Now, this was not on Black population. We wanted to disaggregate, but when we looked at the Statistics Canada data of 17,000 immigrants in Canada, we found that immigrants the major contributing factor was sense of community belonging. So, and we did not disaggregate by race because the database was not sufficiently powered to be able to disaggregate by race. But I just wanted to point out the importance of us building the strengths of communities and fostering community belonging. It's a thing that is amendable to social intervention. The challenge we have is, fostering community belonging in the broader society is difficult because of anti-Black racism. But how do we foster community belonging also within us? And I also like to, the United Nations came to Canada in 2017 and did a study on the conditions of Black communities across several social and health outcomes. And their conclusion is Canada's history of enslavement, racial segregation, marginalization of African Canadians has left a legacy of anti-Black racism and had deleterious impact on people of African descent, which must be addressed in partnership with affected communities. And I highlight that, we cannot move forward, we cannot tackle many of the issues we face without partnership with communities, not by us, without us. So I have also done work in the past looking at researchers who have done work with Black communities, and Black communities identifies the challenges we have with helicopter. People call it helicopter, people call it fly-by-night researchers that come to our community, gather the data, leave, and we don't actually see any benefit for the communities. Or we don't, they don't translate the knowledge. It's only the publication, if you ever see it. And this is a challenge. I have done work related to mental health of Black youths, and now I'm trying to shed light on some of the things that may help us in terms of improving the health of our communities. I've talked about community belonging. I have talked about community belonging, and now sport, I think, is one thing. So during COVID-19, sports venue was shut down, and that is where we realized that sport is actually a vector for social change. And promoting sport can help us in terms of addressing many of the challenges that youths face. And I would say the importance of mentorship. And I think in terms of mentorship, I have a Black Youth Mentorship and Leadership Program. And there, you probably see me on the second row. I somewhere in the middle of the second row. The summer mentorship program that was created at the University of Toronto, of which I was part of and led to where I am today. And I do have a mentorship program. But I put this up to really say the importance of building the capacity of our communities at all levels. And that is very, very important, building the capacity of our communities as fruitful actors and capitalizing from a strength-based perspective. So if we are to develop a national comprehensive strategy to address improve the health outcomes of Black population, some of the things I believe we have to do is we have to engage communities as fruitful actors in improving their own health. Many of the issues that we face in our communities or the particularities that Black people face is anti-Black racism. And that has to be centered historically and contemporary and has to be tackled. We need to consider the social determinants of health and that the determinants of health do not exist in isolation, but they intersect with other determinants, including intersections with gender, housing, food insecurity, and so on and so forth to influence health outcomes. Intersectoral consideration will be very, very important, including with housing, immigration, and several other sectoral services. Capitalizing on the strengths of the communities are important. And in the sessions that we are going to be doing after this, we are going to be looking at what are some of the things that are already happening within the community to be able to actually bring to light and see how we can capitalize on some of those strengths, including healthcare professionals within the community. We need to build resilience. And some of the ways that we can build resilience, as I have said, is through sports. And other ways is also through our spirituality and religion. Engaging community and religious leaders will be very, very pivotal to mobilizing health and positive health outcomes within our multiple communities. And recognizing the diversity of Black communities, that there is diversity, for example, diversity in food, diversity in ways, and attending to some of those unique diversity within our communities. And I think all strategies should also focus on building our capacities within our communities and the importance of centralizing. And also it should be based on research evidence, both quantitative and qualitative. And as Dr. Jude Sinat said, we have increasing qualitative data, but we have limited quantitative data, especially quantitative data that is focused very much on physical health outcomes of Black communities. And thank you, Dr. Sinat, for that national study that you've done in the past on mental health of Black communities. Thank you so much, everyone.
And thank you, Dr. Bukola Slamy. I'm smiling because I know how hard you work, and you've highlighted how important it is for the race-based data to be put into the forefront. We've also noticed that there's some slight variation in data from province to province, as Dr. Sinat has highlighted as well. And I think we'll see that theme in the other town halls as we move forward. So we're a little bit behind. So I just wanted to highlight the instructions for the breakout rooms. So there will be 2 or 3 English breakout rooms. There'll be 1 French breakout room. You will be instructed to assign yourself very shortly to a breakout room of your choice in the language of your choice. If you see a room filling up, you'll just be assigned to the next room. So we're going to take 30 minutes. There will be a facilitator and a scribe in each room. You'll be able to unmute yourself and talk and participate. And the breakout rooms are not recorded, so you can speak at will. There will be a timer at 2 minutes. When the breakout rooms are going to be automatically closing, we'll be pushed back into the main room. So at this stage, I'll let Eki and Nia push us into the breakout rooms. Thank you.
Hi, everyone. To enter the breakout rooms, you need to assign yourself. So if you go on the bottom of the Zoom screen, you'll see the breakout rooms and you have the option to choose one of the 4 breakout rooms based on the language of your choice. So there are 3 English breakout rooms and 1 French room. Please assign yourself to one of the rooms. Thank you.
Mhm.
So I don't so I think everyone is back.
Mhm.
Yep. Yep.
Acha, am I
Okay.
supposed to take this up from here? Yes.
Yeah, I'm
So
gonna leave the microphone. Yeah, go ahead.
Thank you everyone for all the wonderful comments. Now I think we probably have 1 minute each for a report back of 1 or 2 points of what was discussed in each of the breakout sessions.
So I can go first because we actually had a very productive session. And one of the biggest things that came forward was the lack of research on the Black population, but lack of Black researchers. And to go along with that is lack of funding for Black research. And then if we do get the research and get the data, Black community has to manage the data, interpret the data, and also have some data governance, because if someone else interprets it, it can come out re-traumatizing us. The usual suspects were out there: substance use addictions, mental health, racism, criminalizations are all issues affecting the Black community, especially to do with pregnant women, endometriosis, fibroids, breast cancer. We do need more research and more accurate data that we can rely on. And then if there are programs to support these, we need to evaluate those programs. Are they making the impact that they're supposed to? Some of the things that could help in the community is by having some health promotion. Hang on. Evaluate the medical professionals that are actually providing care, culturally responsive care, Afrocentric breast screening, and there was others, but I think my minute's up.
Thank you. And Valerie, are you able to report back in 1 minute?
Oui, bien sûr. Donc, dans notre discussion, ça s'est vraiment tourné au point de vue de la santé mentale, parce qu'on a pu voir aussi qu'on a beaucoup de méfiance des communautés, qu'elle est basée beaucoup sur notre propre histoire, mais aussi que nos communautés ne croient pas justement dans le système de santé. Ne se sentent pas pris au sérieux aussi lorsque les patients vont aller voir un médecin, que ce soit pour les diagnostics, pour les symptômes. Donc, il va toujours avoir une minimisation du symptôme. On voit aussi qu'au niveau toujours de la santé mentale, il y a un aspect de honte qu'il y a aussi dans la communauté, de tabou, qui va être lié aussi, on parle avec une problématique de spiritualité qui va même être parfois le remède justement à cette problématique de santé mentale. Qu'est-ce qu'on voit comme stratégie? Ça va être bien sûr de financer les recherches, de l'éducation. On parle aussi d'incorporer les églises, les endroits où est-ce que justement nos communautés vont être présentes. On parle aussi de former aussi nos cliniciens par rapport à prendre soin de personnes noires, ce qui n'est pas présentement le cas. Et voilà, et on voit aussi, on a parlé, vers la fin, on parlait justement de problèmes de santé mentale qui étaient beaucoup liés aussi à l'utilisation de substances illicites.
Thank you so much, Valerie. Now were there 4 rooms, so there must be one. Okay,
Yes. Yeah, in our room, in the first question, we talked about, we raised the issue of access to education, both for professional programs and for our children in high school and lower level. Also supporting practitioners who intend to use traditional way of practicing medicine so that they will practice effectively. Data gathering and race-based statistics should also be Black-led. And the term universal healthcare is not really universal because most times there's lack of access to Black people. So we should make move to make sure that there's accessibility, there should be outreach, that we take screening services where Black communities are so that it will be accessible to them, to improve access to these services. Even the referral system, sometimes they overstay in queue for a long time. Before they will see a professional, it's already long overdue and it's late for them to get treatment. And focus on the top killers of Black people, chronic diseases such as hypertension, CVDs, diabetes mellitus, including obesity. These are things that affect Black people, including mental health issues and stigma. And we should lobby to get into the federal and provincial governments to have a seat on the table, because by the time we have seats on the table, we'll be able to participate in policy making. Food security issues also were mentioned in terms of also having good policies on how to reach out to the Black people, on making sure that they have access to food. And we also talked about practices that are targeted at helping Black people in terms of treatment in health services and all that. I think my 1 minute is done. Thank you.
Thank you. Thank you so much. In my group, we discussed anti-Black racism, the influence of anti-Black racism, the need for health professional competence in anti-racism initiatives, the need for attending to aging population. So we have a lot of Black seniors, and that population is increasing, growing, but there's been less attention to them. They need to also align with pharmaceutical policies, especially emergent policies. They need to consider health literacy in everything, and also chronic disease management was highlighted. I think from all the groups together, what I can see are some of the common themes that unites us includes the need for research evidence to guide what we are doing, to health professional and anti-racism training. Some people also mentioned some certain conditions, including some chronic conditions that we need to pay particular attention to, and also to address the broader social determinant of health. So thank you for this session. Someone also put in the chat the need to think about the backlash against anti-racism initiatives, and how can we form a strategy towards actually this backlash, because it is a risk, it is a threat that we must attend to. So in our future sessions, we will also look at how can we address some of these emerging issues. So from here, we will be going to our next session, and Dr. Atose Kyoto, I believe the next session is about healthcare professionals, healthcare organizations, emerging programs and policies. Something about program and policies that have been worked within Black organizations to see what are promising practices that we can capitalize on in the future. And then from there, we'll talk about the strengths that we have in our communities, including healthcare professionals. And lastly, we will bring this to a conclusion with a session that will look at policies and how can we begin our discussion and processes to developing a national health strategy. So thank you everyone for attending. This has been great, and it's been awesome to have you join us. And I'll pass it on to Dr. Sekiotu in case he has anything to say.
Well, I was going to give you the final word, but we have an email address that I posted. I know we didn't get to all the questions, but we'd like to thank you everyone for starting this conversation, and please use the email address that I posted to continue with the conversation. And also, some of you have asked whether we can share the slides. We just have to make that conversation with all the participants, but I don't see any problem. As you know, we recorded this session as well. So thank you, everybody, and have a good night.
Bye-bye.
Amazing. Eki, I'm not going to log off just yet. I didn't get a chance to get all the chats, so I'm going to try and go back into the chat rooms and see if I can save them.
Yes.
So I'm not going to end the webinar just yet. I'm going to try and go back in.
Yeah, and the Q&A as well, but great job.
Yes,
everybody.
I was able to get the Q&A and the main chat, but yeah, I'm just going to open them up. If you see that message, it's just me trying to go back in.
Okay, no problem. I've also taken some screenshots of the Zoom chat.
Oh, did you?
Yeah. But I don't have the Q&A questions.
It's funny when we went back from the breakout rooms to the main room, I
Yeah.
couldn't communicate in the webinar chat with the rest of the there was no ability for me to sort of post to everybody.
Oh,
Yeah.
yeah. Okay. Yeah, maybe we can do something, but I also was I don't have my host abilities anymore too. I noticed that towards the end.
So
So
unfortunately someone cut and paste my message to the panelists, but anyway, just
yeah,
something to think about next time. Okay.
yeah. Okay. Thank you so much,
Yeah,
Asil.
that's good, guys. Good job.
Yeah, good job.
You guys did a great job in the background, sort of
Let
putting this
me,
together.
oh,
Yeah.
I think Mia has to stop recording. Yes, thank you so much, Asil. You were